Welcome to Lunchtime Live at the Center. Male factor is a common cause of infertility for couples who are trying to conceive. And since men contribute half the genetic makeup of a baby, it's important to be included in the conversation, as well as important for them to be included in the conversation. So today we're welcoming Dr. Stan Honig, who works closely with the center. He's a clinical professor of surgery in the Division of Urology at UConn Health. He's also director of men's health and a full-time faculty member at Yale University Department of Urology. He's also president-elect of the Society of Male Reproduction and Urology. So Dr. Honig, it's a pleasure to have you here. Welcome.
Thanks. Pleasure to be here.
How do you define male infertility?
Well, infertility in general is defined as trying to achieve a pregnancy for at least 1 year unsuccessfully. And usually when that occurs, we recommend an evaluation both for the male and the female. And we have parameters that give us kind of averages for sperm count and sperm motility. And the guidelines look at the number of sperm and the movement of sperm that is much, much lower than the average. So generally speaking, when you get to the point of 15 million sperm or less,
Okay.
or 32% or about a third of sperm are moving, if you're less than that, that's when we tend to be more concerned. It doesn't mean that if your numbers are higher or your movement is higher, that it could not be a subtle male factor, or vice versa, that you couldn't get someone pregnant, or if the numbers are higher or lower. But those are kind of the general guidelines in terms of how we evaluate the male.
So how common is it? What is the incidence of infertility in the male population?
Well, 85% of couples will achieve a pregnancy within the first year, and 15% of the time, you can have a problem. And of that, 50% of the time, it's a male factor. Now, most men are getting their partners pregnant, but probably 10 to 15% of men will have problems getting their partner pregnant.
Okay. And can you talk about, how we diagnose it? What happened, how it's diagnosed?
So normally, there's a combination of a female evaluation and a male evaluation. It usually starts with a sperm test.
Okay.
And, historically, it's something that would be done at a lab. But actually, in 2021, there are actually home tests now that can look at count and movement on the sperm and things like that. So men who kind of are a little gun shy to bring in a sample, or a little embarrassed, they can actually do the tests at home, and the tests are available to buy from the pharmacy. You can buy them online, things like that. So, and those are really screening tests, but that's usually the first line. And if there's an abnormality, then they usually will come to a reproductive urologist like myself to be evaluated, which may include taking a history, a physical exam, and then a more defined sperm test.
What are some of the things that would be considered abnormalities or abnormal in a sperm test?
So one of them would be that the things that we look at would be, number one, we look at the volume of the ejaculate. So usually there are a certain amount that we would expect, and if it's less than that, we would look into why that was the case. The simplest explanation is, and it sounds crazy, but I missed the cup. So we don't usually just do one test. We'll probably do several tests. By the same token, we'll look at the number of sperm. The average sperm count in men whose wives are getting pregnant after trying for a year is around 70 million. We tend to get concerned when that number is 15 or less. Similarly, with movement on the sperm, the average in men whose wives are getting pregnant after trying for a year is about 50% are moving. And we tend to get more concerned when that number is 32% or less. So those are the parameters that we generally look at: the volume, the count, the movement, and then we actually can look at the shape of the sperm, where A sperm analysis, let's say at the center, will look very critically at the head of the sperm, the mid part, and the tail, and that will give us some more information about sperm quality.
And those are defined, is that where the words morphology and motility come in?
Exactly. So that would be sperm morphology.
Okay, and motility is how it's moving.
Right. The percentage of sperm that are moving with a certain degree of activity.
Okay. And what is azospermia, if I'm saying that correctly?
Azospermia is actually the lack of sperm in the ejaculate. And that's kind of like, people think of that as kind of like the death sentence for fertility, but actually that's really not the case. Because a certain percentage of people, if they don't have sperm in their ejaculate, they may have a blockage. So they could have normal production, and they may have a blockage in the area next to the testicle called the epididymis. They could have a blockage in the area of their ejaculatory ducts. And these things are treatable or reversible. Sometimes they're just missing a part of the tube. They'll be missing the tube that carries the sperm called the vas deferens. And there are ways to extract sperm from men and work with the center to extract eggs and through in vitro fertilization to achieve a pregnancy. That's one part of the azospermics. Those are called the obstructive cases. The other group is called the non-obstructive. Those are a little bit more tricky. It used to be that we thought that those patients really didn't have any options. But we know that when we sample some cells from the testicle, we'll actually find sperm in about half the cases. And again, if we find sperm, we can use that sperm and use the eggs from the wife retrieved from the center to achieve a pregnancy through in vitro fertilization. So, historically, azospermia was thought of, quote unquote, the death sentence of the male, but we know now we have a lot of options that are available. Sometimes there's even hormonal imbalances that can be treated with medications. So that's kind of the overview of the no sperm in the ejaculate, or azospermia.
So, when you talk about hormonal treatments, is that where things like, testosterone or FSH can improve sperm and sperm quality?
Well, it's interesting that you bring that up, because that's a very important point, and it's actually just the opposite. Okay, because men who are put on testosterone, it will actually shut off their sperm production. So we see a lot of men who've been actually put on testosterone by maybe their primary care doctor, or they're actually using it in the gym. They're building up their muscles in the gym, and they're just using anabolic steroids. And what we know is that you have to make your own testosterone to make sperm. And when you take these anabolic steroids or testosterone, the body says, hey, I'm getting the testosterone either from injection or another way. I don't have to make my own testosterone. So it shuts off their own testosterone, and they actually stop making sperm. So you really never want to take testosterone if you want to get your partner pregnant. Now, there are medical treatments that can cause men to have sperm in their ejaculate. For instance, if their brain hormones like the FSH that you were talking about, or the LH is low, sometimes we can put them on some either oral medicines or injectable medicines, like a drug called HCG that can stimulate sperm production and take a man who's either azospermic and turn them into someone who can have sperm in his ejaculate and get pregnant naturally. So I think the important thing here is, number one, there are treatable ways to treat men if you have a low testosterone, but don't let anyone put you on testosterone if you want to get your partner pregnant.
Can someone be on testosterone and then stop and then they could get pregnant, or is the damage done if they go?
Yeah, that's a really good question. And most of the time, it's a reversible issue. Now, we've seen patients who've been on testosterone for 10, 15 years, and those sometimes can be not reversible. But most of the time, if men have been put on for a short time, or they're on a low dose of testosterone, most of the time we can stop their testosterone, Most of the time, they'll bounce back and they'll start making sperm. Now, sometimes the reason for the low testosterone has to be evaluated further. So they may have had a low sperm count to begin with because their testosterone was low. So, but they do bounce back in most cases, to answer the question.
Okay. And does the age of a male of the male partner impact the health of the sperm or health of the potential child?
Now that's a very timely question, or issue as well. The ASRM, the American Society of Reproductive Medicine, and the AUA, the American Urological Association, recently put out guidelines, which are now been published probably about 6 months ago. And one of the new guidelines focuses specifically on the effects of the male relating to age. And one of the guidelines discusses the fact that as men get older, there is a increased risk of birth defects in a child. There's increased risk of having miscarriage, lower sperm counts, things like that. And I mean, obviously, it's the same with women. It's not something that's potentially treatable, but it's important to know that, for instance, men who are typically in their late 40s, early 50s, they have a higher incidence of having children with autism, schizophrenia, and some bone diseases called achondroplasia. Not off the scale, so it's not 10 times higher or 20 times higher, but it is slightly higher. So it is something that we've started to counsel men about in terms of, getting their partners pregnant at a younger age, similar to what we've known in women for many, many years. We know with women, the drop in egg quality really drops considerably over time. And in men, it kind of drops slowly. So it kind of drops little over time. But there is clearly a change.
It's late 40s, around there is when it starts to decline.
Well, the guidelines actually comment, and this is based on expert opinion, it's not based on really hard data, that the changes start at age 40, but they start to really increase much more at age 50.
Okay.
And we're seeing men who want to be fathers when they're older, so that's an issue.
Yeah. Is there anything that men can do from a lifestyle perspective? Can you talk a little bit about lifestyle, medication use, environmental exposures?
Sure. So one of the important factors, and I always say, whatever's good for your health is good for your sperm. Okay. So if you're 40 pounds overweight, sometimes the testosterone gets converted into estrogen in the fat cells. For every 10 or 15 pounds you lose, your testosterone probably goes up 50 or 60 points. And we think that obesity, at least to some degree, can impact fertility. Same thing with things like smoking, alcohol, and I'm not someone who says you have to be cold turkey. I mean, I think anything in moderation is fine. You want to have a glass of wine 2 or 3 times a week, I think that's fine. You want to have a cigarette when you're going out with your friends, I think that's fine. But if you're smoking 2 packs a day, if a man is smoking a case of beer on the weekend, or 4 or 5 beers every night, or 3 or 4 hard drinks, all these things will impact fertility to some degree. So again, anything that's good for your health is probably good for your sperm. One thing that is kind of a wives' tale is caffeine is bad. Actually, caffeine is fine. Underwear probably doesn't matter what you wear. Wear whatever you like. Doesn't matter if you wear briefs, boxers. Wear what you want. Whatever makes you comfortable.
So what about supplements? I'm sure people ask you about supplements that might support sperm quality.
Right. And this is kind of a controversial issue. We know that there are some data to show that certain supplements, specifically things like antioxidants, which are like vitamin C and vitamin E, and a supplement called carnitine, those are the 3 that probably have the most positive impact on sperm. Is it going to bring you from a low level really high? Not necessarily, but in the patient who is borderline to begin with, again, controlling lifestyle factors, controlling things that, a little dietary supplement here or there that's not too expensive. All these things in will help to some degree to improve things.
Okay. Are there any additional like health risks associated with infertile men?
Well, again, I'm glad you're my yes person today, because one of the guidelines points out, the new guidelines, that it's important that the male be evaluated by someone with a history and a physical exam, ideally someone who has expertise in male reproduction, because it turns out that there are health risks that are associated with male infertility. So, for instance, even though it's a small percentage, maybe once or twice a year, a patient will walk into the office with a low sperm count. We'll find a testicular tumor or something like that, or we'll find a pituitary tumor, or we'll find a genetic abnormality. So I think that, or a low testosterone, that is something that may need treatment down the line. So health risks are associated with male infertility, and going to an appropriate person to take a history, physical exam is super important, especially when starting out.
Excellent. You briefly touched upon this, but what are some options available if sperm can't be obtained from ejaculate?
So in someone who has no sperm in their ejaculate, or someone who has maybe a low sperm count or things like that,
Um,
or either.
no sperm count, no sperm usually.
So no sperm, again, if it's a blockage, and it's reversible, that's a treatable, reversible problem. Sometimes if there's a blockage in the ejaculatory duct, we can unblock them and they get pregnant naturally. Sometimes if there is a blockage in the area of the epididymis, we can do a microsurgical repair. And again, you got to find someone who has microsurgical skills to do this. And you can achieve a pregnancy naturally. If there's not something that's reversible, then again, we can go in and get sperm either in a blockage case, someone who has no vas deferens, or someone who has like a non-obstructive problem, where we actually do this kind of, it's called a micro dissection procedure, where we actually open up the testicle and we look inside with an operating microscope, and we actually pluck out certain areas that may be more likely to find sperm. So there are options that are available in the male who has no ejaculate, no sperm in his ejaculate. Now, there are also options above and beyond assisted reproductive technology for men who have, let's say, a low sperm count, low motility, and that's where the physical exam and evaluation comes in. Some men will have what's called a varicocele, and these are big dilated veins that sit around the testicle and can heat up the testicle. The testicles sit outside the body because they're a couple of degrees cooler. And when you have these big veins, the blood goes into the testicle, and instead of leaving, it actually can pool around the testicle and affect the quality of the sperm.
Okay.
If you fix those veins, 7 out of 10 men will see an improvement in the sperm. So that's one thing. Sometimes there can be hormone imbalances that we can treat. Sometimes there can be blockages that we've talked about. And sometimes there can be infections. So there are many treatable, reversible causes of male factor infertility.
Okay. And what you had mentioned, if there was no sperm, but what if there is some sperm? What are some options?
Right. So that's what I talked about,
Okay.
just recently, which is the maybe fixing a varicocele. If there's a hormone imbalance, sometimes there can be an infection. Sometimes they're on something like we've talked about. Something they're on testosterone, we take them off that. Sometimes they're on a different medication that can affect sperm quality. Sometimes there can be problems with erections, where the transit getting the sperm to where it needs to go can be a problem. So there are a lot of different nuances in terms of things that can affect the male and that are treatable or reversible.
And what about a male who's had a vasectomy?
So that's a special case, because in men who have had a vasectomy, there are two options. One is to reverse the vasectomy and get pregnant the old-fashioned way, okay? And that's through a microsurgical reconstruction. The other option would be to just go in and retrieve sperm. And that's an office procedure where we go and get the sperm, and we would work with the center, where we would work with one of the reproductive endocrinologists where they would stimulate the female to get oocytes, and the oocytes would be retrieved. We would have gotten the sperm, and we put them back together through intracytoplasmic sperm injection. So great options for patients who have had a vasectomy. Most of those couples we can help.
Science is amazing. Dr. Honig, I really appreciate your time today. Thank you for joining us.
Okay, my pleasure.
Yeah, for anyone who'd like to schedule an appointment with Dr. Honig, he sees patients in New Haven, the Shoreline, and in Farmington, and I will add his office phone numbers in the comments section. So that's all for today, and you can get more information from our website as well at yukonfertility.com. Have a great day. Bye for now.